All right, recording in progress. So, Lily, I don't know if you just wanted to kind of lay out your protocol, like here's step one, two, three, four, five, and then here's the details on step one. Let's ask questions. Here's the details on step two. Ask questions. Does that format kind of fit what works?
Sure, sure.
Does that work for you, Dr. Krishan?
Absolutely. That's kind of what I'm looking for, kind of to see how a rough template that you follow, and then we can modify it to our practice as if needed, to apply to what we're doing. Because I know we follow a few different rules from your state than our state, I think.
Like what?
Can you guys hand out us home sleep studies?
No.
So like that one, and then like the medical billing company that you use, things like that, little processes like that. But the overall, my main thing is when the phone calls come in from that point, like when we're using Todd services, I want to see how we can maximize that. And I know you've done that to a T. So maximizing that using your flow and then inserting our little parts as needed.
Sure. So we get a new consult request or whatever it is. I usually try to block 2 times out of the week. We usually do, sometimes the patients will send in their lead request and then they'll actually call right back, basically. If they don't, that's when I block out about like 3 hours, 2 days a week. And that's all I focus on, just doing the backup calls to them. I'll call them. If I leave a message, it's, "Hi, this is Lily from Sleep Better MetroWest. Just wanted to see how our office can help you with your sleep. Give me a call back. Here's our number," whatever. If I get someone on the phone, I'll start asking them questions of like, it's very organic. Like that's the other part of it. It's not really like a this yes, this no, this, so I'll ask them, what was it that kind of had you click on our link? Usually it's, "Oh, I hate my CPAP. Oh, my girlfriend's gonna like smother me because I snore so much," like whatever it is. And whatever that is, that becomes part of your discussion with them, basically. Let's say they said, "My CPAP got recalled." "Oh, so you have a CPAP. How long have you used your CPAP?" So just make it flow as part of the conversation more than anything.
Yeah. And Lily, do you have what's your goal in those, while the questioning might be organic, what is your goal in the line of questioning that you have?
The goal is just to realize the value of what the product we have is and how we can help them. And they've reached out to us so that that there's already some sort of problem, whether it be snoring or they hate their CPAP or whatever it is. So the goal is to add value and to start them on a conversation of how we can help them sleep better, whichever way we do, basically.
Now, before they speak to you, I know they go through the click funnel and they're clicking random things. I'm not 100% sure how we're kind of funneling them down. But once they do that, do you have them fill out a sleep questionnaire or something like that before they speak with you?
No, not before.
Okay.
I don't want to overwhelm them too much because not every patient, like I have different forms for what I get out of this conversation. Like if they've never had a CPAP, never had a sleep study, there's a screener that I would send to them, and then I would refer to one of our like local sleep docs, just to get them not help per se, but at least it's something, it will be helped, but I don't know if it's going to in turn become a sleep appliance, but at least they're getting help with whatever snoring or whatever they're getting. I had one guy who called in. He's actually the one, his girlfriend was going to smother him, like if he had another night of snoring. And he ended up being a severe apneic. He was 74 times a night. 74 times an hour. So we might not be able to help him, but he's getting the help he needs. So, is it a waste of time? No, I don't think so. Because again, the ultimate goal is just to get them help, whether it's with us or someone else. So that's like one. So if they come in and they have just snoring and they haven't had a sleep study, those are the ones that will be sent just the screener, because we can't administer it in Massachusetts. I didn't know that Texas was a state that could administer, unless that changed recently. Okay.
Ever since we've gotten training since Dr. Osborne's, like 3 years ago, when I first kind of got into it, we were able to dispense home sleep studies. So we kind of right now, we're just working on our internal patient base. We tell them, hey, these are the signs and symptoms. This is what we see. Have a conversation, and then we send them home with the home sleep test, whether it's the sleep image or whether it's it used to be Brabon, and now I'm using the watch pat. And then of course, then what I do is it's all cloud-based. So once the information comes in, it goes up to the board certified sleep physician. They read it, they give us a diagnosis. It comes back to us read, diagnosed already, and then we go from there.
Okay, perfect. So your process will be a little bit different because you'll be able to keep a lot more of it inside. You're not kind of throwing them out into the world of sleep docs and hope they come back. And then the same thing, you probably still want to try to find a network of sleep docs, because if you do get one of those severes, you'll want to send them out anyways. And then it's a nice networking process. So that's another question. Now with the funnel, we're able to know if they've had a sleep study or not. And what's nice about having the sleep study is you can kind of almost start with those, because those are people that have had a sleep study, have had a CPAP, and the best ones are the CPAP and sleep study. And then you figure out why they're reaching out to you. And those are usually easier to convert into appointments, because at that point they've already tried the CPAP, either they hate it or whatnot, whatever it is. And then they kind of, at that point, you would send them the other forms that we have, which is more the medical history, with still including the sleeping and the snoring and all of that. But it's also much more in-depth medical history as well. And then from there, so you just kind of have to decide which way this person that you have on the phone goes, whether they're just a sleep screener. They fill out the sleep screener. Once they fill it out, you send it off to your, well, we would send it off to our sleep doc. You would probably still want to bring them in if you're able to dispense. And then on the flip side, if they are able to, they already have a CPAP and they don't like it, can figure out their sleep doc. I usually, depending, just so that they kind of get a little bit more skin in the game, I have them find their sleep study and email it to me or fax it, whatever. And then from there, I would set up sending them those paperwork, and then I would set up a Zoom call with them.
So you give them homework essentially before any type of consultation.
Yeah.
Okay, and that homework is fill out this medical history online form and submit that to us. If you've had a sleep study, fax that to me. Go get it from your doctor, and maybe an Epworth.
The medical history has the Epworth in there,
okay.
But I also tell them, just so that I kind of have an idea. Sometimes I get it before the Zoom appointment. I ask them for their license and medical card so that I can verify benefits before also.
Okay.
And we've talked about this before, but you've noticed, like, on this, there's no discussion of cost, because that's not the
Krishan, she is one of the few members of Dental Sleep Profits that have come on who understand value proposition. Like, I don't think she'll have any issue with people instantly getting on the phone and saying, well, how much does this cost? I don't think that's going to be an issue for her.
Yeah.
Which is-
And that's
which is
also
good.
just part of the value of it, because you don't ask if you have like a heart replacement, what's my out-of-pocket cost? That becomes not a non-issue because it needs to be done. A lot of times, like when you're talking to them, they'll be I had a guy today, actually, he's like, I'm on high blood pressure medication and they keep changing my dose because I'm not controlled. And that's now become his motivation for why he needs to get this done. He tried the CPAP, tried 6 masks over 2 years. He's done. CPAP has kind of made its way to the side of the bedroom. So, or in the closet, I think is where he's at this point. So he,
Where do you usually find the hesitation or the resistance? These patients, to me, if they're already funneled and they're like, okay, I don't like my CPAP, I want to go to this place that has the alternative. So usually with our patients, we're bringing it up to them that they have a sleep issue. They don't even know they have a sleep issue until we talk about it, do a sleep study, and then, they have a AHI of 38. So with our existing patient base, we're doing a lot of education, which I know you'll always do a lot of education. I was curious, and we'll find out as we go, sure, as this calls start coming in. But what I was curious is these calls that are coming in, I'm thinking because they're funneled, they're already motivated because they know they have a sleep issue, or are you finding majority of these patients don't even realize they have a sleep issue?
so that's also something that I also trigger about what time the lead comes in, because sometimes the leads will come at like 2 a.m. or 1 a.m. or 4 a.m. So you can also bring that as part of the conversation. Like, oh, I noticed you chose to send in a lead at 3 a.m. What's that about? And that becomes part of the conversation, because some people are like, oh, my girlfriend says that I'm snoring so much and that's why I needed to do this. So they're not really like owning it yet, almost, because they're sleeping. So they don't have a problem with their sleep per se. And then our Epworth has obviously the screener one has the Epworth, the Thornton, and then the questions of like, is it hard to lose weight? Is it hard to, I fell asleep at a traffic light, those questions kind of thing. That's on there too. So then that also, now they're starting to own it a little bit of, oh, there's more to this than just sleeping badly.
We have Epworth, and we also have our own sleep questionnaire that we've gotten from Vivos. Would you mind sharing your questionnaire with them so I can see which ones are overlapped and which ones?
Can you share yours back?
I'll pull it out right now. No,
yes, I will. I promise.
I'll say I'll do it, but I won't do it, and she'll make sure it gets done. We'll send it to you for sure, absolutely. Because one thing, when I went to ASBA in Phoenix back in, what was it, two months ago, one thing that did come up, and I ran into this in real life with patients, is when I have them fill out the Epworth, especially if they don't even know that they have an issue or they're not wanting to own the issue, the Epworth comes out really low. All of a sudden, after we have the discussion and talk about how things are related and give them that, then all of a sudden the numbers go high. And then another discussion, I'll say, listen, if you're super defensive and you don't answer this honestly, insurance has less reason to want to cover this for you. So now's not the time to be shy. Now's the time to be honest and put everything on there. So I usually am able to have that discussion and I see a more realistic answer after that versus giving them the Epworth score ahead of time. So right before we jumped on the call, I was talking to Noelle about this, is I'm hesitating to give them the Epworth score, so the scale ahead of time. I like the questionnaires that just talks about symptoms. So have you seen that same issue? Are you noticing that the Epworth is coming out differently or no?
So I kind of have, like I said, I have the Epworth and the Thornton, and then these other kind of extra questions that'll help, like, do you have diabetes, high blood pressure? So the comorbidities are also on there. So if you've got a lot of these comorbidities, you might be caffeinating yourself and then you don't need to sleep. So those are also questions that are on our medical history. Like, how often do you caffeinate? Do you do drugs is another one, stimulants, melatonin is a big one also that we ask about. So it's kind of not just the Epworth as opposed to it's the overall picture of what it is. Because some people are very well controlled, like, but it's not necessarily exactly a real life situation. Like
And
you said.
I promise not to digress too much, but Dr. Gali is also an ASBA diplomat too, right?
He's not ASBA. He's no, he's not ASBA. He's
AADSM.
yeah. AADSM. Thank you.
I remember.
Tended to be both. Like whoever I ran into or whoever those speakers were, they were diplomats for both.
We've attempted ASBA, but they don't answer us when we ask questions about, are there any courses that kind of overlap between the two? So
I do know they're in the process of changing, I think, because Dr. Caulfield is now the new president, so things are changing. So
I think a lot is going to be changing soon.
okay. Okay, like I said, I won't digress too much. But okay.
So the diplomat does end up helping every once in a while. Like when you're sending letters out to physicians or you're sending letters back to physicians, it's nice to have that portion towards the end of the signature for sure.
And I'm getting that. So as
what
far
else?
as we were, so now we've got them to a Zoom consult.
Mhm. So at the Zoom consults, like Todd was saying, I have their medical insurance already. I have their sleep study. I have their in-depth medical history. And then I have in office 2 samples. One's a herps and one's a dorsal. Especially the ones that have already been CPAP intolerant or non-compliant, those are the ones I'm more, showing them what the appliance looks like, that sort of thing. But basically the way that the consult goes, we get on the call. I go over their medical history. I go over their dosing, their snoring, how many times you wake up. Do you ever find yourself jerking when you wake up? Tiredness, all the symptoms like we were talking about. And then we go through their sleep study, because a lot of times you'd be surprised at the number of patients that have never had someone go over their sleep study. And that's the part that just like baffles me, because I always tell them, I'm like, oh, what's your score? And I wait to know if they know the number or if they know just mild, moderate, severe. Because mild, moderate, and severe, it was like, we need to delve into that a little bit more, because it's not salsa. It's actually like a condition. It's not just mild and moderate. And then
Texas, we're totally stealing that.
I just laughed. I laughed out loud on mute. It's not salsa.
It's not salsa. And I tell them that, and they're like, you're right. Because a lot of times they might come in with like a mild or moderate, and then their oxygen levels at like 82%. So they're like, I'm like, do you realize what that means? And then we'll kind of go into that physiology of what does it mean that your oxygen level is that low? And then they're like, no one's ever told me that. And I'm like, it's right there. It's right there on your report. Like, and so then we'll go over that a little bit. And then of course, like I'm listening to them as to why you don't like the CPAP, what's wrong with it, what's happening in your family life, what's happening. And that's why it's not really where it has to be organic. Like you have to listen and you have to apply what they've said to why they need to come in. I mean, you don't have to, but you should like use that part of it. And then from there, I'll show them what the devices look like. And then they always ask, which one do you think is good for me? And I say, that's what the dental exam is for when you actually come in. Every appliance can work in every mouth, but it's about comfort. And I just give them 2 examples, like some mouths, their tongue is too large and, there's an appliance for that. Or their mouth is too small or they just have severe TMJ issues, there's an appliance for that. Huh?
I said there's Vivos for that.
And there's Vivos for that.
You have to get
So
to Vegas for that.
we're going, I think.
You're going for sure?
I think so.
Okay.
I think that's the plan for October. So that's what I tell them, that, you know, every appliance will fit in every mouth. And then I also give them the disclaimer, because my models are just like massively large, that the model is 2 size and my hands are small. So I make everything look super large in my hands, because what I didn't realize, I had been doing this for an entire year. And then finally a patient comes in and he was like, show me that model that you showed me. And I'm like, okay. He's like, oh my gosh, show me your hands. And I was like, okay, my hands. He's like, your hands are so small. You make everything look so big. I thought I was going to like choke. And I was like, so that's actually what you're not going to do. Like, this is where we have to go backwards on what we're doing. So I give my two-part disclaimer before I show them the model. And then I show it to them. And I said, you know, there's over 300 designs. Dr. Galley kind of keeps between 7 to 9 that he's actually using, but it's kind of, you know, dependent per patient, what makes the most sense for them.
Okay.
And then I also explained to them with my hands that I don't have any models of like the airway or anything like that. I just kind of show them on my hands. I tell them that I ask them first what they know about the oral appliance, because that's also really fun to see where they are in their awareness of what's going on. And then I show them that the oral appliance will kind of keep their mouth the way it is when they're awake, that the lower jaw is moving, the tongue stays with it. Very, very basic. And so I tell them that we pull the jaw forward. Obviously, I'm exaggerating how much. And then that way the tongue will stay forward, because what happens when we're sleeping, everything relaxes, back of the throat, the tongue, the lower jaw, everything relaxing, ends up no oxygen flow. And then I explain that the CPAP kind of throws air back through the throat, and that goes past the obstruction. This removes the obstruction. And then I show them the different models. I have a herps and a dorsal. Like I say, I show them herps first, and then I show them dorsal. And then I ask them what their thoughts are. And then I also show them, because a lot of times it's like, oh, I heard this is awful for my jaw joint. And then I show them that we work with an AM aligner for that, to bring everything back to your neutral positions. And then I ask them their opinion and whether they'd want to continue me getting authorization for them, basically.
So once
that was going to be my question, is Lily, at the end of that Zoom call, what's your call to action? Is it just like, what do you think? Like, is that
It's what do you
basically it?
think? And do you want me to seek authorization for you?
There you go. Okay.
I need to get a yes. Otherwise, I'll say, okay, let me know what you want me to do.
Perfect.
Do you do this with patient and spouse typically? Sometimes if they said girlfriend made me do it, do you have them go or just with the patient?
Just with the patient, because the Zoom calls are all complimentary, because they're with me and where I'm not a provider of a medical provider. So it's complimentary. It takes like 20, 30 minutes, but it weeds out who's not going to be a good candidate, basically.
So once you have that,
Not a good candidate. That's probably the wrong word, but like who hasn't taken responsibility for their apnea, basically.
they have skin in the game. You know, they're really
Yeah.
willing. They're really serious enough about getting treatment or finding
Exactly.
so it's time for my doctor's appointment. So I'm gonna head out. My only question, the only question I had, and I'll let these girls take notes on the answer, is on the onboarding process, step 4 was the videos. And so sometimes I get lost in details. I love videos. I love doing them. Surprise, surprise. I have no hesitation with that. My thing was, I was showing Renata, is like, oh my God, they have like a great model. Two of the guys had a great model of a head with the Aries on it. And then the other one had a head with the CPAP on it. I was like, well, now I can't do the videos because I need to get those first in order to do videos. True or false?
Just go steal a mannequin head off of something at Macy's and
Okay.
So I don't have videos up.
You
So I'm a bad answer from this. I've been yelled at, I've been told to do it, but I actually don't like videos. My first of these Zooms were all without photo.
How did Todd get you on all these? Because we've been binge watching all your videos on your YouTube channel, Todd. So
I know. As long as it's personal, Lily's fine. It's when she's given like, hey, record this, here's some bullet points to hit. She's like, nope, not comfortable. Dr. Galley's not comfortable either.
It's not happening. And he's like, okay.
We are actually in the process. I'm lining this up to have us produce those videos as like, hey, I'm one of the coordinators here at the practice. That way it can be across the board. Anybody can use these videos if they're not comfortable creating them. So eventually that will be available to all our clients. Obviously, some people are more comfortable on video than other, but the point is we want everyone.
Obviously, some people need them more than others.
So like sorry, my laptop's here on this lower thing, but I'm a DI, so my point of questioning was a little bit different than my team. These guys are C's, so get ready to get drilled because a lot of questions, especially this one over here. All right, thanks guys.
Bye, Dr. Krishan.
Bye.
Okay, I'll scoot in here. Yeah, I watched a lot of the videos already, so I'm trying to think if I have any questions, because one thing we were discussing is maybe I'm the hygienist at the practice, and then we have an assistant who does a lot of this clinical side of the sleep. But we were thinking maybe one of us doing the Zoom calls initially, and kind of like what Lily was explaining, weeding out, see who has skin in the game, and then we can ask those last two questions. What are your thoughts? And do we have the authorization to get the information from your medical insurance? And then we can have someone get that and then kind of go from there. So I don't know. And Dr. Sandhya does a really good job with the sleep consults, because once we get, let's just say we have authorization to get information from their medical insurance and everything, then at that next appointment would be really Dr. Sandhya kind of, well, I don't know. I'm just thinking, would you recommend going over the sleep study there? Because you don't have their sleep study yet. So we would ask them to email or fax the sleep study, right? That they've already taken. Is that correct?
No, I actually have the sleep study before I have the Zoom.
Oh, okay. And that's when you go over it. Okay. So we would be going over the sleep study with them.
But you'd probably go over it because your process is a little bit different. You'd probably go over it after you get the equipment back from them, not necessarily attaching it to that initial consult Zoom. Do you know what I mean?
So at your initial consult, you are or you're not going over the sleep study?
I am, but mine are always coming from somewhere else, whereas yours are like already internally. Or
yeah, because if the person already has a sleep study, you can ask them to fax that to you and you can go over it on the Zoom call. If they have not had a sleep study, you guys are able to distribute that from the practice. You can check out a WatchPat or a ResMed, whatever you guys are using, and get that data directly when the patient returns the unit. Whereas Lily has to say, okay, you need to contact your primary care or you need to contact this sleep doctor to schedule a sleep study. And then we can have our Zoom once you get that data back and complete your sleep study.
Yeah.
So that's kind of how your guys' processes are a little different.
Different.
Yeah. Okay. I think the other thing where we're going to be a little different is because we do also offer Vivos. We kind of, what we've learned is how to present it differently. We have a more permanent fixture or appliance that you wear temporarily for 2 years. And now we have another appliance where, you know, you wear this indefinitely. And then another thing I note in one of the videos, I think you have them do a follow-up sleep study, usually 30 days after they're in the appliance.
Me?
That might have been Dr. York.
Okay, sorry, I'm getting my videos mixed up then.
Yeah. So yeah, Dr. York, sometimes he will, if the patient is willing, he will have them do another sleep study 30 days later while wearing the appliance.
Okay.
And then he'll use that data to show the patient, like, look, here's how this is working. And he'll also use that sleep study while the person is wearing their appliance. He'll distribute that with the patient's permission. He'll share that data with local physicians and saying, hey, I just wanted to show you, you know, this person, he'll reach out to the patient's primary care, for instance. I just wanted to show you, here was our patient's, very important language there, our patient. Here was our patient's AHI prior to wearing a sleep appliance. Here's their AHI. It's now at 4 while wearing the appliance, or 2. And the primary care is like, oh my gosh, like I didn't even know this existed, or that it was that effective.
Okay.
So we do it at 90 days. Like once their symptoms have resolved, we will do just a titration, which is usually a night owl, which is just around the finger. And then we get that data and we do the same thing. We send it back to primary care. Yeah, but not 30 days, which might be another
Yeah, Cuffy does it I believe he does it at 30 and 90. So sometimes he does 2 additional sleep studies. So,
and those are kind of inclusive in the pricing, because we had an issue here where doctors are like, don't do sleep studies. And I'm like, it's not even titrated. Like, it's not even, I mean, it's not even scored. And so we were very hesitant, and we have it that this is not an official sleep study, like watermarked on it, so that they know that they can do whatever they want to confirm also. So that was just a boundary issue with some of our doctors.
Okay, got it. And I'm just thinking, in one of the videos, Lily, that you did, I saw that you had said it took about 90 days for you guys to start getting, I guess, I don't know, the leads or the good leads or something along those lines. No.
No, we were at like 35 days, and I was thinking to call Todd to stop because we were getting a lot of leads. I mean, of course, in the beginning, the questions you ask and how you kind of word it with them. And like other times it was, you know, when you make your goal just to get a Zoom appointment, that doesn't become value for the patients. It's really about creating the value. And if you make an appointment, you make an appointment, right? A lot of times, and I think I'd said this, like some of my first ones, like I kind of created value, but not enough to want a Zoom call. And then 2 or 3 months later, they'll call and be like, okay, I tried the CPAP again. I hate it. Can we like figure out what's next in the process? Because they knew that we knew what we were talking about, and we already have all their information, but they wanted to try the CPAP one more time or whatever, as if, you know, the first 3 times weren't good enough.
I think at the 30-day mark with Lily's campaign, that's when we implemented the new pipeline in our dashboard, where we filtered out Medicaid leads, and Medicaid leads went in their own automated follow-up. That way you guys aren't calling them on the phone. And then I think at like the 90-day mark, Lily, like that's when we started tagging patients with either CPAP or sleep study, so that you could prioritize who you were following up with. But that's Like that's already in your guys' campaign. You guys has adopted all of the changes that
You're
Lily and
welcome.
Dr. Galley have insisted like would help them. So you guys get that benefit.
Okay, awesome. Sounds good. Well, I'm excited to start and see how it goes.
Can
Yeah.
you guys hear me by any chance?
Yes.
Yeah.
Awesome. So when you take that initial call or you call them back from the lead and you get a little bit of initial conversation going, what's the verbiage that you use typically that the first Zoom call is for? Like if they go, well, what am I doing the Zoom call for? How do you explain it to them, Lily?
So I just tell them I am going to, after I get your sleep study, we'll go over your sleep study. After you fill out your medical form, we'll go over your medical form. I have some samples for you, and then we'll decide if it makes sense for us to move on to the next step.
Like that. Okay.
So it's just all about setting the expectations of
Exactly.
like
Okay.
what needs to be done.
Mhm.
Okie dokie. All right. I think.
And then
so the
after they come into the chair, it's all the doctor's time. Now the doctor has to impress and go from there.
Yes, then the weight's on my shoulders. My question is, Todd, the only little tweak I wanted to make on ours is that I think on the initial funnels that I saw, it was all like me and my name. I'd like to tweak it a little bit to make it Robert, both of our names, because depending on, and we both do sleep, so depending on what day they come, what hour they come, if I'm out or whatever, then I want to make it so that they know that there's two of us.
Yeah, and I think we did update your guys' funnel pages so that Robert is included. His bio is in there as well. Yeah.
Awesome. Perfect. Y'all have already sent that to me to see that one? Or is it the same, like if I go back to the old email and click
Same
the
link.
old? Okay, perfect.
Yeah.
All right. Awesome. Okay, cool. And then, oh, sorry, one more. Videos. Videos, do we have a deadline for those that need to be, those videos need to be done by?
No, as you
Before
well, as
we go
you can
act-
tell, Lily is very successful without video.
Yes.
We do have images that we use that that convert very well that we have made.
Okay.
But video will get a lot of traction. So the sooner the better. But we're not waiting on you to finish those videos to go live.
Imagine
that's
if
what
we
I was
waited
gonna
for us.
I do have, I use Fiverr and I got a little animated video made with a avatar of Robert and I in it. And
There we go.
that explains, I kind of borrowed, copied from Somnimed, but we modified it to us. So I'll send it to you and see if you can use that as a placeholder.
Okay.
If
That
you
is
think
fun.
it's good. I'll send it to you for fun, Lily, so you can see it too. But I'll send it to you. If you think it works, great. We can use that as a placeholder. If not, then I'll just get I'll get our videos done ASAP.
Cool. Perfect. All right. Do you guys have any more
All right.
questions? Like maybe, well, like Lily said, once after the Zoom, if they want to move forward, it's doctor's time.
Yeah.
So,
I just wanted to understand Lily's part from the moment that the phone rings or we get the initial lead to the point that they see the doctor. I want to make sure that we're doing it. Basically, when someone has a success formula, you just copy it, right? You don't have to reinvent the wheel. So I just want to copy her success formula and then tweak it for us as needed.
yeah. Now, Lily, did you have any pointers for dealing with medical insurance? Or let's say someone says, I really can't pay out of pocket for Vivos, but I do still want to address this issue. Like, can my insurance help at all? You're like, yeah, absolutely. You know, insurance will cover a mandibular advancement device. And let's say they go that route. But the person's like, oh, my deductible is like $10,000, like something astronomical. You know, would it be helpful for you guys if you understood kind of her process for dealing with with patients who maybe have mild objections or they want to address it, but they financially, they understand that this is going to be a stretch for them?
I'm always open about.
Oh, I think she froze.
Yeah.
Sorry, Dr. Krishan, you went into robot mode and you're frozen. Sorry. Here,
What do we think she was asking there?
Yeah, I don't know. But I don't know. Maybe, I mean, Lily, obviously you have patients who are very, very motivated to move forward, but they still have these, let's say, a $6,000 deductible. And
Again, it's all about.
Oh,
go ahead.
Even though, like, I know you told me that you had 3 calls this week already, not a single person even brought up price, which is great. But eventually the discussion does come. Eventually.
It does, but that's why I do, I find out what their insurance will cover. And then if you can get the gap inclusion, I don't know if you guys have done that yet. So that kind of helps a little bit to also alleviate some of their costs. Because if they have a 6,000, let's say, in network and 6,000 out of network, they're going to have to cover that 6,000 before anything gets done anyways. So I do that, or I do a cash payment also.
Yeah.
A cash option. Cash
And
option.
you do that in-house in like 3 payments, right?
Yeah. Yeah.
And what's your fee structure for that?
I do half, quarter. Half, and
Half,
then
quarter.
a quarter a month later, and then a quarter a month after that. So because most of our patients
you're
are
basically
completed.
a 90-day risk.
That's exactly what I was going to say. By the end of 90 days, when we're doing, look at her picture. By the end of 90 days.
She's like, they can't freaking hear me.
By the end of 90 days, they're kind of at their optimal positioning anyways. So we'll have kind of the payments all fixed by that point as well. Okay. The one other thing is I don't, and this is something for Dr. Krishan, I don't tell them that they're going to have an appliance, I tell them that they'll come in, they'll do the exam and possible impressions. And the possible impressions is because, you know, in our office, Dr. Galley needs to confirm that you're a good candidate. Yeah. And he always laughs at me. He's like, what are you doing? I walk in and they're like, I need to be a good candidate. I need this device. So that's kind of another setting expectations. Not every patient will be a candidate, but you know, we'll try it and see.
Yeah, Dr. York had a great example of that. There was a member of Dental Sleep Profits that was struggling converting leads. And when I was talking to Dr. York about this other member, I told Dr. York, I was like, you know, Dr. York, you're getting half as many leads and converting 10 times more patients than this other member. I was like, the patients aren't any different in West Virginia than they are in wherever. And he goes, oh yeah, there's a big difference, Todd. I was like, what do you mean? He goes, they have less teeth in West Virginia. And he goes, that's part of my process. I actually have to ask, how many teeth do you have? Like, if you got at least 4, we might be able to work with that. But
that's part of the medical history. Do you have dentures or not? Because it makes a big difference, obviously.
Yeah. All right. Well, thank you guys so much. Do you have any questions?
I have no questions. Okay. Thank you.
This was really helpful, guys. I really appreciate it. Thank you.
Lily, I did email you our sleep questionnaire.
Oh, thank you. I will send you mine, I promise.
Thank you.
All right, guys. If you have any questions, just shoot them to Hazel. And if you guys want to go direct to Lily, are you okay with that?
Of course, yeah.
Okay, but if it has anything to do with the dashboard or the campaign, Hazel is available and she can point you guys in the right direction.
Will do. Thank you so
much.
much.
All right.
Good luck,
Thanks, guys.
Bye.
Bye.
Bye.